There we go.
Here we go. We're live.
Now we are live. Hello, Facebook world. For anybody who's tuning in. So this tonight sort of stemmed from Eric and I starting a podcast a few weeks ago and talking about a couple of papers that Ben Darlow et al. Had written. One of the ones mainly talked about client, community, and clinician and how those things have an impact on people's pain. But we looked at, I think, 4 different papers, Eric? At least I wrote 2 blog posts on 4.
Yeah, I think we had I think we looked at 3 of his papers and a couple other ones. I can't remember. We were talking about this off air. And I was like, we recorded this podcast over about 2 months ago, so I can't actually really remember exactly what it is we talked about. But that's why we have TJ and Jocelyn and Stephania here to kind of remind us what we talked about and ask us questions.
Yeah,
I'm sure it'll come to you when we get talking.
TJ had several questions that he wanted to unpack and chat about. So that's kind of what we're going to do. And of course, anybody is welcome to drop questions into the comments and they'll pop up for us so that we can see them and we can bring them up on screen and we can do our best to answer them. But let's get the chat going. TJ, what was the first one that you wanted to talk about?
So this is the place where I get to put you guys on the hot seat. I love it. Love it. So, yeah, so as I was listening to the podcast, and this often happens, is, listening to stuff and then just so many inspiring things coming on, and you just wanted to, I want to write stuff down. I want to unpack it. I want to explore it more. You guys did a great job, and there's so many great, big, almost like a chest of knowledge that you could just if we just open that up and sift through it a little bit and talk about the details. I got inspired to ask questions kind of like that. So here we go, right? I don't think it's in any particular order. So the first thing that I have written down here is about applying a biomedical approach to the biopsychosocial. Maybe we could talk a little bit about, I want to hear what you guys have to say. Maybe there's some examples that you can give of how this can really easily be misused. Can you comment on that stuff?
I'll go, Eric. Some of the stuff that was brought out in the papers was where, whether it was a doctor or a practitioner otherwise, was believed that the biopsychosocial was the appropriate framework of pain to look at. They still tended to go back towards the biomedical. And while they understood that there were psychosocial factors involved, their descriptions of what they were saying to patients was still from very much a biomechanical resource or standpoint. And that's where the fall down started to happen, because they were still giving descriptions that were biomechanically based rather than looking at psychosocial factors. So that, I think that was one of the big things. And Eric, you can add whatever you remember from it.
Yeah, I think if I remember correctly, I think that comment or that discussion was because when we're looking at biomedical being very linear, very one-to-one, here's a problem, here's the solution. I think what we were talking about is how oftentimes people will replace the biomedical with the biopsychosocial. So they'll still look for that fixing mindset where it's just very linear, here's the problem, therefore we're going to fix this. And I think, TJ, when I was listening to you talk recently, you were mentioning that the way the biopsychosocial, the thought processes of it are often biomedical in their reasoning, meaning that okay, well, if we know that tissue pathology or tissue state and kind of the pathoanatomical model of pain and of wellness, it isn't really that strong in a lot of cases, particularly as things persist. Oftentimes, people try and replace it with the biopsychosocial, where they start looking at, okay, well, maybe it's just your thoughts, your beliefs, your fears, your sleep, your anxiety, depression, whatever, all these other non-mechanical things. And people often will try and say, okay, well, this is what's causing your pain.
Yeah.
So they basically replace biomedical with the psychosocial, and they're using the same kind of linear reasoning framework.
Yeah.
And I think that potentially can be even more of a problem.
Yeah, I see that trend too, right? The change from, instead of saying it's your psoas or it's your whatever, instead of naming the body part, you're now naming it's just because you're stressed. You've got a lot going on. It's just because of that, rather than acknowledging that it can be all of the things together. They all go in the bathtub, right?
Yeah, and I think it's especially looking at that, saying that it's just because.
Right?
Nothing is just because. That sort of minimizes that you've got something possibly serious or important to you going on. By minimizing it, by saying that. That's a lot of what the papers were about, is the words we use. So sorry, I didn't mean to cut you off, Stephania.
No, I was talking over you, Jamie. Sorry, bad habit. No, I was agreeing with you just fervently. It's so dismissive, that messaging of, it's because you have these other things going on, obviously, right?
Yeah, I think it's an oversimplification of it, because I think as generally in healthcare, we were always looking to fix, right? We were like, someone comes in with a problem, they see us, they want us to tell them what the problem is, and they want us to fix it. And all of us in our profession have been educated to think, well, let's look for the right technique to address the right tissue, and then we will fix it with a specific technique, and then your pain will go away. And then the pain doesn't go away, and then we apply a different technique or a different modality, and that tries to fix it. But then when we start say, okay, well, we know the biomedical isn't that strong for these things, then maybe let's pick up the biopsychosocial. So now we're like, okay, yeah, we're still going to do this technique, this thing that makes you feel good, but then we're going to try and pain science educate you to make you like think differently, and therefore your pain is going to get better. But what happens when they don't feel better?
Yeah.
What are we saying then? That they're just thinking wrongly about their pain, potentially. And I think those things are very damaging.
We pain science them even more then.
Yeah. And like the thing with pain science, I was having a conversation with one of the physios I worked with, is that like pain science is good at helping people who experience kinesiophobia and have a higher risk of catastrophization, but it doesn't actually help with their pain. So it's, really understanding like what message that you are saying to the person in front of you and why you're saying it and what outcome or what takeaways you want that person to take from your message.
Point of clarity, that when we say pain science in this context, are we all saying about how a practitioner might want to use some pain physiology informations and education to help them understand their pain? Okay, good. Yeah,
like pain.
Not applying pain science as a technique on something.
Exactly.
It's good that we have TJ here to kind of bring us back to be like, right, let's talk more simple.
We're talking to each other, right?
Yeah.
And we all know what we mean when we say these big words that need to be unpacked. And this is kind of part of the reason why I wanted to have this, is because there's, otherwise it becomes this like secret code, right? And then like, it doesn't necessarily translate. And I want to make sure that it translates too, right? Because otherwise, then what are we doing it for?
And my big bias, I think, I think understanding pain science is way better for clinicians to understand than it is for patients. I think it's really important for us to understand it. That's my bias. But I think patients don't really need to know all the nitty gritty of it as much as I think we do. Because I think if we understand pain, it allows us to kind of think and reason differently with what our patients are experiencing.
Yeah. And we've got a great comment here from Samantha Page. She's saying it's super uncomfortable to a person looking for a solution to say, well, I can't make your pain go away, but I can support you while you have pain. Is that what we're moving toward? It can seem like a bit of a letdown. And I would say that's totally what we're moving toward, that we're supporting the person along that journey. Because they're, no matter what, they're going to come in and say it's the first time you've seen them, and you're trying to communicate with them and give them somewhat of a reason as to why things are happening, and say they get better over a few treatments, but then they have a flare up and maybe a setback, and we're going to be continually trying to work with them through their process until hopefully they're either out of pain or managing their pain better, or living daily life and understanding that pain isn't as catastrophic as what they possibly thought before.
And going like for purely selfish reasons too, it's actually better that we play more of a supporting role, because if you hold on to that I'm going to fix you narrative, when it doesn't work, how disappointing is that to a therapist? And that I find from like conversation with other RMTs, that's what leads to a lot of burnout, is because we view our roles as a fixer. And when it doesn't work, then we start self-doubting. We start wondering why this isn't working. And then we get let down and disappointed, and we almost get wrapped up in that person's experience more than they do, or we're more invested in them getting better than sometimes they are. And so I think it's better that we play like more of a coach or more of a supporting role, just even for our own selfish longevity.
I'd like to add to that, just because you're bringing the therapist perspective, and that's awesome. And it's funny, it's fresh in my mind, because I was talking about the case, working with Eric in a group today, and a case that I was working with, kind of a complicated case, been going through a lot, for a few years, worked with pain BC, etc. Had every treatment on the planet, right? So when you're looking at a patient who's had treatment after treatment after treatment, this is relatively failed treatment after failed treatment after failed treatment. Each time I'm thinking that each time that happens, there can only be one or two logical ends for the patient's reasoning. Is one is that their therapists are idiots, and that's not necessarily true either, right? Or they must be more screwed up than they thought they were, because nobody can fix them, right? So what a burden for them to carry.
And in all fairness, I've been the idiot.
Yeah, me too.
All of us have.
Oh, yeah.
Probably still continue to be at some point.
100%. Thanks.
All the practice. We're learning as we go.
Idiot crew.
I think it's good though, because I take a lot of solace in knowing that I fucked up so much previously, and then you kind of use those as learning moments to be like, this doesn't work.
Yeah.
Or I messed up here. And I mean, you feel bad, and we've all done it. Yeah. But I think holding on to old shit and just like keep on going through that is not helpful. But if you can say, okay, I did this thing, or I thought this way, and this is what I did, and it didn't work, then you're being honest. I think I think it's a better sign for you as a human, and as a healthcare provider.
This kind of deviates from, I mean, it's on par with what we're talking about, but it deviates a bit from the articles that we were starting to talk about. But what Sammy was saying there, I mean, I wish that when I was a student, I had understood that it's not your job to fix someone, and you might never get rid of their pain. I don't recall ever being told that. I had the onset when I was a new therapist that if I didn't help someone feel better, I thought that I was a failure, and they certainly thought that I was a failure too. There was no educating me that I'm helping them manage. We might be able to decrease your pain. We'll see how it goes. This is a trial and error, and for the patient to set them up for their expected outcomes. What can they expect the result to be from treatment is that we're helping you. We're not necessarily getting rid of it. Yeah. Right.
Well, I think that's such a great point, Stephania, because I think what happens is it leads to an entire culture of people, and not just our profession, but all kind of healthcare professions, looking like this continuous search for the modality, the intervention, the technique, the thing that is like the coup de grace, the thing that is like the best, right? And if you just keep searching, and I think we've probably all guilty of this, where you keep searching, you jump into like, oh, now I'm like, insert your favorite acronym here, therapist, or now I've taken this workshop, or I've been to this conference, and now I'm going to like lean towards this way of thinking, or that. And I think it ends up, you end up kind of searching constantly for the thing that you think might work best. And I think it ends up, we end up moving away from what the things are that are important.
Yeah. Which
is being okay and experimenting and not having all the answers.
Mm-hmm. And that was actually one of the things that was brought up in these papers, was that when we're acting that way, and we're not using good communication, and we're putting those things onto patients, it actually can lead to more disability.
Mm-hmm.
Yeah,
it can get to the point that it's not necessarily improving, or what would be the opposite of improving, or making pain worse.
Aggravating.
But it's making disability worse.
Yeah.
Which is far more catastrophic for somebody than just making pain worse or better. Because if we're actually showing them how they can manage their pain, then maybe they can get through those ADLs and maybe they can still go do the things that they enjoy. But going the other way, we're actually making it so they can't do those things, and that's terrible.
That's a little bit of a difference between pain and suffering.
Yeah, you guys keep talking. I'm gonna go turn the lights on.
You go, Joss.
Oh, I was just gonna say I might be shifting this away a little bit, but something else I've been just as our group has been talking about, like that linear thinking within the biopsychosocial framework. Something that actually came to my attention today in practice was the linear thinking of the person in front of you, and I think that's something that maybe we don't take into account. And that we really have to watch our language around that, because so in the case I saw today, this was someone who was led to believe that they had a weak lower back. And so they had to do all these core strengthening exercises to strengthen their back. And this person had more core strength than I do. Like they could pike, they could do all this crazy thing, all in pain, but they were very functional. Mm-hmm. And so when we were interviewing, I kind of asked them, like, well, why do you think your back is weak or your core is weak? You can do all the stuff and I can't do this. And we actually went like toe to toe in the studio and did it together. And like they out-strengthed me. And I think that was like a awakening moment for that person. And I asked them, well, what made you to believe that you have a weak back or a weak core? And they said, well, all my clinicians or all my therapists told me that I need to strengthen my back and I need to strengthen my core. So they took that message of strengthening as I have a weak core, I have a weak back. And so now I'm shifting that strength message to you need to increase your capacity or your tolerance to something. I'm actually avoiding using that strength word because of its association with weakness.
Interesting.
I like that.
We're all talking over each other here. That was brought out in one of the papers, is that when they looked at the patient's beliefs about back pain, that vulnerability of their back was a massive one, where they actually assigned it and basically said that their back has its own identity and it can decide when it's going to get hurt and when it's not. Mm-hmm. So I mean, I don't know that it went into like where that stemmed from, but that was just the belief, some of the beliefs that people had that later led to a bad prognosis or disability and pain.
Mm-hmm. Yeah. Sorry, Eric, your turn.
Oh, no, it's okay. I was just going to say that the one thing I found was really interesting with these Darlow papers was the patient viewed the back as weak, as fragile, as easy to injure, right? The clinicians kind of felt the same way, that the back was weak, fragile, and easy to injure. And the clinicians would say, okay, well, it's important for you to keep moving, and that because that's what the guidelines say, but be careful of your back. Right, be careful how you do things. But then also too, and they talked, because it was the client, the clinician, the community in these papers. The general community consensus was that the back is weak, is fragile, it's easy to injure. So it's kind of like everybody believes this, has this belief system about the back, which actually is based on no evidence, but because everybody believes it, right, the clinician and the general population. And this is in New Zealand, and we could probably say this data is probably similar here or anywhere in North America or Europe or South Australia or whatever, right? Anywhere that's kind of similar culturally, economically as us, right? It's probably very similar. The people have these beliefs that are unhelpful, and they just because it's just like everyone believes it, everyone talks about it, so therefore it must be true, and it just gets perpetuated again and again and again. And I thought that was really interesting, actually, when I kind of took a step back and realized how this is a problem in society, and it needs to stop.
Yeah. We walked through the magazine rack and just looked at like the article titles in women's health or men's health or whatever. I haven't looked at them in a while, but the last time I did, it was a whole lot of better fire your transversus abdominis. Oh, your psoas might be the issue. Your back, how to keep your back strong by doing core exercises. All of those things, right, that perpetuate those ideas that patients have walking in the door.
Yeah, and really interesting too, because that's one of the points that it made about community, was that if there was a recent media campaign about low back pain or back pain, that influenced people's beliefs and the outcomes that were happening in a clinical setting.
Thanks for bringing us back to the article over and over, JJ. Brilliant.
Yeah, we kind of like go way over here, and then like Jamie brings us back, and we go over here.
I think that's what we were here to talk about. So,
Well, it's funny, when the five of us were talking earlier, some of you guys were like, "Oh, I can't remember. I haven't read the article." I was like, "We're not going to talk about the article." Barely. It's just we're just going to chat about wherever this goes. It's going to be a free for all.
So while we were just talking about the one of the Darlow papers, the 2015 one, was saying like about just we're talking about the culture, the cultural narratives, the cultural beliefs about low back pain. I thought it was interesting because that they almost said it in a dismissive way that, you know, they thought low back pain was special, but low back pain is special. It's you know, considering it's the #1 cause of disability in the world, it's the single most costly healthcare burden in the entire developed world, costing, you know, way more than cardiovascular and cancer combined in the U.S. $100 billion a year problem, right? There are special pieces to it. People that are off work for more than a couple of months, they have like a 50-50 chance of going back to work. Although acute low back pain has a favorable prognosis, sort of. We like to say that it has a favorable prognosis, but it's still only sort of, because more than 50% of those people that do self-resolve, and the majority will self-resolve, but they within the year, they will have at least one major exacerbation. So who's to say that it's resolved? So I agree that that the narratives, whether that just be for the clinicians and additionally the community beliefs and all that kind of stuff, that probably makes it a lot worse. But I don't think it's fair to suggest that low back pain isn't special, because I think it is. And it is that scary.
I think it loses that specialness because of how common it is. And I think that's why it comes across as dismissive, is because it's just so common. And and reoccurrence too. It's like, if you know, one of the best predictors for lower back pain is a previous episode of lower back pain. So I think it's just, and I agree with you totally, it is a special thing. It's just, it's so common that it's often dismissed as not special.
But I wonder too, and I've never looked at the stats on it, so I would be making it up if I tried to put that on it. But is it really that much more common than neck pain, or is it just that we give it that much more attention?
No, it's not. The #1 reason why people actually the #1 and #2 reasons why people see their doctors. First one is headache and neck pain. It makes it above low back pain, but low back pain is #2. It's the second most common reason why people see their GPs.
Well, I would argue, I mean, again, like Jamie said, I don't know the stats on this, but I would hypothesize that, you know, when my back hurts, I can't put on my pants, I can't leave the house, I can't drive to work. When my neck hurts, I can still get dressed, you know, or if I sprain my ankle, I hobble, but I'm still able to get to work, and then I can sit down. Back pain, where you're uncomfortable in, you know, whatever position you need to be for your ADLs, is more debilitating in that way, just because it's so centralized and such a large part of our anatomy.
I would agree with that too, Stephania. I think the low back pain, and anyone that's suffered low back pain, we all have, is way more disabling than neck pain.
Right. Yeah.
Disabling. Yeah, that's the magic word right there.
If you had to, you know, if you had to quantify it on like a 10-point scale, you know, it could be the same, or maybe neck pain's worse, but you're definitely, your ability to function is a lot worse with low back pain.
Right.
And I don't know about you guys.
In my experience.
I don't know about your guys' experience, but I know in my experience, like, the uncertainty around what is causing low back pain is like more of a, like, people are really scared about that versus like the uncertainty with neck pain.
Yeah.
Like if it's a headache, you know, you don't see people like, you know, wanting surgeries and like all this imaging. Like, it almost kind of gets shrugged off by the medical community as like, it's just a tension headache, or it's just a migraine. But when it's your lower back, it's like, oh, you know, am I checking for herniations? Am I, you know, like, do I have some kind of fusion going on? Is there arthritis there? Like, there's like a degree of more fear I find in my clinical experience dealing with people who have like this non-specific lower back pain than with any kind of neck pain.
Yeah.
Well, that's what
non-specific neck pain.
Hey, Jamie, is that what the article said?
Yeah, imagine.
Big
when,
brain.
when it looked at the prognosis of back pain, because people wanted a prognosis because they wanted to know what was going on, the things that stood out were whether the back actually had the ability to heal, the time frames, and the quality of healing. And a lot of people, their thoughts were influenced by the idea that their back was so vulnerable. So that kind of plays into what you were talking about. We've got a great comment there from a question from Samantha, that if we shifted the narrative, do you think the incidence and severity would also shift? I think it would.
I think it would, but I think it's more than just one. Well, I mean, if you're talking about influencing the prevalence of low back pain and the disability factor with low back pain, as TJ was talking about, then it needs to be like a universal societal or commonwealth shift, as Danny was saying earlier.
Well, I think they could probably look at studies because I know that in other, like, I think it's like Asian countries and things like that, where they get more support from family. They spend more time like in a squat position and things like that. The back pain isn't as big a deal.
Yeah.
There, but in the Western world, we make such a big deal about it so I think to answer that, if we change the narrative, I think it would totally change because it happens in other places.
Do you think?
Oh, sorry. Go ahead, Jocelyn.
I was going to say too. Do you think that also has to do with the way that our medical system is here is a very passive system versus it's a find and fix versus when you're looking at areas where people have to work, like they have to be active even though they're in pain. There's like that movement component there that we just don't maybe see here, where it's like, oh, I have to stay off my back, I have to rest, I have to wait for this MRI or this consult with the surgeon. And that's kind of where my brain's been at a little bit here, is that, we look at movement interventions for lower back pain, but I mean, my clinical experience, getting people to kind of, or trying to get them to engage in movement that they like, or re-engage them in activity that they're scared of doing, almost becomes like, that is really my primary role as a caregiver, is giving people permission to move again and how to manage their pain.
Reassurance.
Yeah.
It would be great if we talked more about reassurance back when we were in massage college.
Exactly.
Or in any post-grad course. How many, technique courses have you ever been to back before I got more woke? A lot of them. And how many people talked about reassurance? I don't remember talking about it. No.
Well, that's the number one thing that's listed in every single guideline, reassurance, right?
Reassure.
One thing
if you look at our medical system, like it's so much, you have low back pain, so you go to a doctor and you get prescribed a painkiller.
Yeah.
That it's supposed to be this quick fix thing, rather than providing reassurance, rather than building resilience in the person, rather than showing them that they're capable and have capacity.
Yeah.
That's so interesting. I wonder what the prevalence is among medical practitioners, so not RMTs, but like medical doctors. Are they reassuring people about back pain? I haven't heard anything about that.
I think they just, I know from the Darlow paper, one of the takeaway, I read I can't remember which one it was, but they talked about people going to their GP, and the GP tended just to refer to a musculoskeletal healthcare provider. So the opinions of those patients and of that GP's knowledge was actually lower than when they went and saw a chiro or a physio, because the chiro and the physio were viewed to be more of an expert in that area. And then the ortho surgeon was like, if we're looking at that hierarchy, they were at the highest. Like that opinion was valued the most from people.
Mm-hmm.
Which, when we looked at the paper, there was an example of a guy who had some low back pain, who was a construction worker and went to an orthopedic surgeon. And when the ortho looked at the x-ray, looked at him and said, I think he was a bricklayer or something, and said, you're a bricklayer. And he goes, yeah. And the doctor looks at him and he goes, well, you're fucked.
Oh, honey.
And that was the verbatim in the research paper. So those messages are still being conveyed, because they're still doing well, you've got the back of a concrete worker, so you're screwed. And I think it said that the person ended up having to change careers, which was based simply on what somebody said to them.
Yeah.
Well, it's no wonder that these cultural and community beliefs are still so prevalent. We're just starting to get some GPs to maybe take it easy on the imaging when it's not necessary, even though I think that the American Physical Therapy Association, especially, has made a really, really big deal about trying to educate GPs, saying, "Hey guys, like slow your roll on things like imaging and even minor stuff for the knee that they don't really need to do because there's not really showing any efficacy, but especially the imaging thing, right? But they're still doing it, and I think I have a slide on it. I can't remember what it is, but it's like something like 34% of doctors still refer for imaging, even though all of the experts say, "Hey, bro, like slow your roll on that because we can't really tell unless you're looking for tumor or infection or whatever."
Yeah. Great comment here from Susan Shipton. Says, reframe the negative to be less negative. Ask them what activities they can do and enjoy despite the pain, not what activities exacerbate the pain. I love that because that's showing them that they're capable of doing something and building that resilience.
I like that a lot. Your patients are lucky, Susan.
Yeah.
Well done, Susan.
Yeah.
You must have good people around you to help you.
And then our brilliant friend, Kev. Learned helplessness due to lack of successful interventions can make a person with chronic low back pain despair and spiral into worse and more debilitating episodes. Also, the fear of making pain worse in these cases disables initiative in the patient to try anything new to improve. Great points, Kev, and that's a lot of what these articles were about.
One thing I thought was interesting, sorry.
No, you go ahead. I feel like I've cut you off all night, so it's your turn to cut me off.
Guys, for like questions.
I'm just kidding. One thing I was going to say that came up, if in the paper, if I remember correctly, was the doctors were aware of the importance of kind of psychosocial stuff, but their whole lens that they were doing things was through like they were looking for pathology. So they were focusing on like you have back pain, okay, but we're going to rule out anything more sinister first, and so that their whole reasoning and interventions went to make sure there was nothing terrible. Which often led to further investigation, which led to worse outcomes. I don't know if that was in this paper, but I know I read that in something else that was similar.
I was actually, that's a beautiful point for me to springboard off of. So thank you.
It's like you planned it that way.
Yeah, I know, right? But one of the points I wrote down here was actually how we need to reframe our view of assessments in our practices. And in school, we're always taught, like, when you perform an assessment, you're performed to like look for something to fix. Like you're looking for the thing that's wrong. And I think now, especially if we are taking more of a biopsychosocial understanding of the person in front of us, our assessments need to be, we rule out the scary stuff, but then we're showing them, like we're verbalizing to that person, like, look, I'm performing this assessment, and this assessment is ruling out all the scary things. So really, this isn't, you might want to use your assessment to like reassure that person more that, it's just cranky lower back. It's just a cranky lower back, or it's just non-specific. And we don't have to worry about these things because if we did, all these tests would be positive.
I came to the realization a little while ago that orthopedic assessment is just another form of graded exposure.
Yeah.
Do this movement. Cool. Do it again. Okay, cool. Do it again. Look, you went further. Great.
Yeah. Or maybe an expectation violation where somebody comes in and they're like, I've definitely got this. And then you do the test. And I say this sometimes to people that are a little bit more, let's say, worried, for lack of a better word. Or the nicest way to say it is they're really worried that they have this thing. And then, so I do a few tests on it. I ask them, gently if they mind if I do a little assessment. So I do my thing. And then after a few of those, then it's like, I'll let them know, like, if you had that thing, you want to punch me in the face right now.
Yeah.
Yeah.
Sorry, there's a dog outside barking at me.
I use testing for reassurance all of the time.
Yeah.
Especially when someone's in pain, it's debilitating. I have this patient right now, she can't get her arm up very high, like 90 degrees. I can't find a pathology wrong with it. It's not a frozen shoulder. It's not all the other things. And so I can see her looking at me and floundering a little bit and be like, well, this has been going on for so long. I can just imagine the wheel going in her head, panicking, what's wrong with me? If you can't fix it, then what's going on? And we could do all these tests and say, well, the good news is that this shows it's not that, and this shows it's not that, and this shows it's not that. So what you've got is cranky. So we're, and this is our treatment plan. It's so decatastrophizing to use.
Yeah. And I think like if the profession as a whole could kind of shift in that direction, like biopsychosocial is going to be a while. I get that. But if we can shift in a direction where our assessment does more to reassure people than confirm scary things, I think that would be so much more helpful in our world anyway. Speaking
of springboards, perfect timing, right? So one of my other questions, beautiful segue, is just I'm going to make a quick comment and then see if we can transition. I'll ask you guys another question. Is if we could maybe, I would almost call that qualitative outcome measures for our patients. What's our assessment? Well, we're looking at qualitative things like it hurts when I blank. Well, let's see if we can get you to do that. That to me makes a lot more sense than trying to figure out what's wrong with it once I rule out all the big scary stuff, right? So again, it's a qualitative approach. So I remember Eric was saying on the show that he was talking about qualitative versus quantitative outcomes and why that might be important to the future of manual therapy. But I wanted to ask you if you can expand on that. Why might that be helpful?
Well, I think because what we do is, let's look at, so if we're looking at research, I think the comment I was talking about was about if we're looking at research for massage therapy, which direction makes more sense for us to go. And I think, there's obviously a value with quantitative and qualitative measures, but I think because of the nature of what we do, it's more important for us to try to do research which looks at the quality of what we do and how that impacts the person. So the person that comes in to see us, how is massage therapy impacting their well-being? What is their experience of seeing a massage therapist? Somebody who's got neck pain, low back pain, shoulder pain, someone who's got OA, how is that impacting their quality of life? And what are their needs, their wants? What is it they're looking for from a therapist, for example? And so that way that can, I think, help inform us for treatment strategies that might be more beneficial for that population. Whereas if we're looking at quantitative stuff, what we're trying to do is we're trying to assign numbers. We're trying to assign data that says when I am in this specific population and I get this specific intervention, it works better than this other intervention. And you're assigning numbers to that. Mm-hmm. Well, you're already like putting this very like linear thought process to being like, okay, like there's only so much that we're measuring here. But what's that mean to the person that's getting that treatment? I think that it's much better than just giving a data like, oh, the effect size is 0.43 versus 0.65. Like what's that mean? For us as massage therapists, we're not statisticians. That doesn't really mean a lot. It means that, okay, maybe this intervention might work better than this intervention. But when we look at the manual therapy data that's already out there, it basically says everything kind of works the same as long as the therapist is comfortable and confident with it and the patient meets their expectation and their expectations are met. So why do we need to keep on trying to compare different interventions? Which is what you see a lot of in like massage. I guess what people are wanting to do, like they're wanting to compare my modality is better than your modality. So I think what makes more sense is that try and understand the experience of people and what it's like for them who are suffering, and then get a richer understanding of what it is that we could provide as a profession.
And we've got
Does that make sense?
Well said.
Yeah.
Was that just a lot of word casserole? Yeah.
I think we should switch it from qualitative research to meaningful research because make it what's meaningful to the
or person-centered research.
Yeah, which leads into a great comment from obviously somebody I'm a big fan of, our buddy Keith Meldrum. Comes in comments.
Thanks for watching, Keith.
What I actually like about this comment is it has a word in there that I don't use enough, and I don't think any of us use enough, is if we treat and support the person rather than focus solely on the pain pathology. I think that goes in line with everything we've just been talking about, but I'd love that word support. I don't think we use it enough, just in my humble opinion.
Yeah, I think that's great, Keith, because I just want to let you know if you're still listening or watching since the interview I did with you a few months ago, I've changed everything I use to supportive self-management now. That's all from Keith. So that support I think is really, really important. So thank you. You want to bring up those other ones, Jamie? There's a couple other really great comments there. I don't know if
Well, there's a couple, because when we're talking about dealing with doctors, Tamilyn Youngblood, I hope I'm saying your name right, Tamilyn, that in her experience with low back pain, at initial injury, the doctor gave no reassurance whatsoever, just said take Tylenol and rest and no referrals. So hopefully that's changing. I think to some degree it is. And then Erin Singer comments that when she comes in, or when a patient comes in to her who has imaging, then they go over the results and then can reassure them that things are normal. So the communication piece is huge, and then they can go on and do active movements and things like that. And Marie Cote. Dr. Rita Sharon, Narrative Medicine, speaks of the 4 great divides between practitioner and patient that impede positive health outcomes. Beliefs about disease, causality, and feelings of shame, blame, and fear are 2 of the big ones that we as manual therapists tend to get tripped up into with our patients. That's great. And that's also a lot of what these papers are about, is the way that we're communicating with them and how our beliefs are actually put onto the patient, and they kind of like absorb our beliefs. And so if we're telling them that their back is fragile, they're going to take that and believe that for goodness knows how many years down the road.
Yeah. And that goes with Darlow's his first paper, this 2013 paper, which talks about the enduring impact of what clinicians say to people with low back pain. Mm-hmm. Right, it says that basically clinicians were seen as providing the most certainty, right? So patients come in with pain. Obviously, this was on low back pain, and they're wanting certainty from their clinician. So whatever the clinician says, that is what they're going to kind of take on. So I think we have to be aware of that. Like, I think it's really important for us to really embrace that impact we can have in both a positive and a negative way.
Because we can have a massive influence in the positive direction.
For sure.
Right, and it talked about that in the papers as well. But, I think part of what we're doing is trying to answer some of TJ's questions, and I think he's only asked 1 so far.
I've asked a couple.
Too many. It's fine.
And you're generating even more, so that's great.
Yeah, me too. We're 42 minutes in, and we've answered 1 question. Great start.
You guys bring up something super interesting. I don't think there's necessarily an answer to that, but I'm just curious, how it is that you deal with this interaction? And I keep running into this, and people keep asking me this, something along the similar lines is, if we want to support people and it's not all about like fixing them, and we want to reassure them, but how do we reassure somebody who's agitated, maybe obstinately adhered to their own narratives about what's going on with their pain? How do we reassure this person without trying to hijack the narrative that is like they're blanky right now, like they believe that, right? So I mean, just for people who are thinking that it could be one way or the other, it's not just tell people they're going to be fine, because that's not true. So what are some of the ways that you kind of weave this in a supportive manner, let's say for a patient who has problematic beliefs that are getting in the way of the recovery, such as very common things like my glutes aren't firing, my core strength is bad, I don't stretch enough. I mean, these are the common things that we hear that are not necessarily true at all. And for the most part, they're not true at all. But when they're really adhered to that, and you want to be supportive and manage that, getting that therapeutic alliance and making sure you invest in the relationship and balancing that with these problematic beliefs that you believe are getting in the way of the recovery. Go.
I think, well, at least when Eric and I teach together, I kind of go off on tangents about this and just talk about dropping little seeds. And it's actually, I think that's advice that we've gotten from Keith too. For those of you who don't know, when Keith commented earlier, he's an advocate for people who live with persistent pain and has lived with persistent pain for a long time. And a lot of it is just dropping little seeds of education. When that person first comes in and they've got all those beliefs, if you just vomit education all over them, you're not going to get anywhere. However, if you just plant a little seed the first time, and then maybe the next time, you make a note in your charts that's what you talked about, and then maybe expand on that a little bit the next time, and then maybe you drop a new one the third time, and you continually try to build on it. It's probably not going to completely change the person in a couple of weeks, but maybe over months and years. I mean, hopefully it doesn't take you years to get them better, but hopefully over that longer period of time, you're starting to make that change. And also, if you can read your patient and they're receptive to it, then by all means, hammer them with more education. But I think that's where you got to use your clinical decision making and see how they're reading what you're putting down and work with it from there. And I'll let you guys go on.
I take a different approach because
Yeah, I was just going to say the one I use is the one I got from Johnston. So go ahead.
I might have changed my approach since then because like today was like a game shifting day for me in my practice. So, which is good. Those are always good days. But I've been working with someone that has very strong mechanical beliefs about their spondy and their back. And like chiropractor, and if they don't see this chiropractor 3 times a month, they're going to experience like lower back flare up. And so this person's been seeing a chiro 3 times a month for the past 20 years and still gets lower back pain. So I asked them, or I told them, I'm like, I see that, you know, that spondy is very important to you. And it, like confirming and reassuring or showing them that I understand that, you know, their narrative of their spondy and their lower back pain is important to them. How can I support you today? That's all I ask. I don't offer a narrative. I don't really drop seeds anymore. And that person was so blown away that I asked that because they had no experience to today of a healthcare provider ever asking them how they could support them in their pain that day. And towards the end of the appointment, it's only been like 3 or 4 times I've seen this person. They asked me, what do you think is going on? And when they ask me that question, that's when I know that I've built a good therapeutic alliance foundation with that person. I actually don't offer anything until they ask me, because then I know that maybe there's a little more buy-in, and then I'm very careful about how I deliver that message.
Nice.
I love it. Yeah, the only thing I was going to say, and this is what I've got from conversations with Jocelyn and others before, was that usually if someone comes in and they have beliefs which are seeming to be impeding their wellness, for example, I'll ask them obviously what they think is going on, which is what you said, and which is I've heard TJ say that before, and I think that's important. What they think is going on, and then I'll ask them: how is this helping you manage your pain?
How's that story helping you manage your pain?
Yeah, how is it like thinking with this? Is this helping you with your pain? And usually people will be like, well, I don't know, I'm still in pain. Okay. And then that will usually, I find, by asking questions like that, helps them to kind of question that, well, maybe what is going on with me, and maybe the path that I'm on for treatment, this kind of fix it, looking for the one person, they kind of doctor shop or therapist shop, might not be the best. And then allows you, I think it gives you that space as a therapist to say, okay, well, let's try something different. Right? If everyone else is just throwing you on the table and massaging you like a piece of meat and then telling you to stretch and strengthen and go home with this very kind of vague kind of treatment plan and ideas, I don't know if that is the best thing. Do you need honey? So anyway, that's where I go with that. There's some good questions which I'm trying to kind of read at the same time as I'm losing my train of thought.
So great comment from Kelsey Christensen. I think after Taylor Soaz's presentation, I'm guessing that's what it's from. Or was it from something earlier today that you guys did?
No, that was a SOAS one. Chelsea was there, I think, on Sunday.
So helping somebody who's a power lifter with their scoliosis.
Oh, yeah.
That's great. Good stuff, Chelsea. So Robin Lancaster has a question for all of us. Something that was highlighted at San Diego Pain Summit was that there's a lack of examples on what treatments might look like with pain-informed practitioners. Any interest in showing those of us who are newer to the arena what your treatments and interactions look like? I, for one, would love to see them. I think it's, I'll just start off because I'm reading the questions. I think it's different for every person. I had somebody a couple weeks ago who was a chronic pain person for 30 years, and the treatment was 35 minutes of a conversation and 25 minutes of treatment. And then the next person that comes in, it could be that I'm doing movement with them and doing a treatment. So I don't know that there's any one right answer, Robin, but trial and error with each person is one way to go. But I'll let you guys go off on what you would do.
It changes. Person to person is always different.
I think it's the whole N equals 1 thing, right? So everybody is different. Yeah. You can have a general idea and framework, and I'm sure the 5 of us would all agree that you have a general idea of how you would, but the person in front of you is going to dictate where you go with that. Mm-hmm. Taylor earlier, and the thing we were doing earlier today was he had his client Donna, and I'm sure and Taylor was talking about, I'm not sure the word you use, but I'm just going to put this in there. You're kind of like a clinical chameleon. where you kind of change to the person that's in front of you and try to adapt to what makes them feel most comfortable, and whether that's language, your how you're questioning and whatnot. So I think the only way to do that would be to do like some role playing stuff, which is something that I don't know we could do. Not today, but we could do in the future. Do some role playing stuff to see, but it's going to be different for everybody. I think that's, and I totally understand what Robin's saying, because I know when I started on this journey many years ago, I was like, well, what the frick do I do?
Yeah.
And it wasn't until I stopped asking that question that I was like, okay, I just got to figure this out within this umbrella of knowledge. But it did help to watch and interact with other people.
Yeah. Some of those Peter O'Sullivan videos would probably be good if you haven't watched them.
Yeah.
Sorry, I lost your name, Robin. If you haven't watched them, if you just Google Peter O'Sullivan, there's a number of videos of him on YouTube interviewing people and doing different things, which are pretty valuable. So they'd probably be worth the watch.
Yeah. Well, I'll take a gander at this too, because she asked, it was kind of like a panel question, which I like. Robin, I love that question. You know, my treatment doesn't look much different. To be pain science informed, it probably looks more like relaxation style massage than it used to before I started going to all these conferences and reading these papers and getting more informed. It used to look a little bit more orthopedic. Now it will still do that, but really what's changed the most is my interaction with my patients. So, hey, what's the most delicious to you? I want this to work for you. What is it that you've had in the past that you like, that you don't like? I really use the word delicious with them a lot. I'll ask them, is this intensity? I don't talk about pressure. I talk about intensity. Like, is this intensity here working for you? And if someone says something to me like, well, you can go harder, I'll go, do you want me to go harder because it would be more delicious to you, or because you think it might be good for you if I say so? Because that's not how I jive with people, and I'll, like, these are all languages that I'll use with them. I don't know if that's helpful at all, but.
Does it feel SFN? Is it so fucking nice?
Oh, fucking nice.
Touch people nicely. Final answer. Reassure them.
I'm dying to jump in on this, like, Robin. Awesome question, because like that's the big question, right?
Yeah.
So what do we do? What do I do, right? And like really, mostly you just got to go forward and screw up a lot, and then just learn from that. But a couple of things come to mind, and first would be, I think that if we have a better intake, like there's a reason why I have this really big ass intake, and it's because it gives the patient the opportunity to already set the stage for me to understand what it is that they're looking for. So just as an example, you can email me or you can contact me on Facebook or whatever, and I'll send you my paperwork just for an idea. If you want to chat about it, I'm down. But like, I'll ask them questions like, this is my first time with them. I'll say something like, okay, so just to get an idea of the kind of massage therapist that you're looking for, I'm going to give you 3 statements, and then can you please tell me what is the closest one that you identify with? And the first one would be something like, this is an inconvenience. I just want to get back to work, or I just want to get back to my life and the things I want to do. Like, I'll just do whatever I want. I'll do whatever you want me to do. Just tell me what to do, and then we can move on. That's like attitude number 1. Attitude number 2 is something like, I've got some regularly occurring aches and pains. It's no big deal. It doesn't get in the way of my life or anything. But massage is like one of my favorite ways to deal with it. And number 3 would be something like, relaxation is 100% the most effective thing that I can get out of a massage. And no matter where I hurt, my head, my shoulder, my hip, it doesn't matter. If you give me a nice, beautiful, silky, like smooth massage, then like that's going to take me down the most. So these are 3 different attitudes, and they can be somewhere on the spectrum. People give me mixes, but right then they tell me what kind of massage therapist they need me to be. And just, lastly, when I'm working with them, that can translate into something just as simple as, I'm doing, knuckle stroking in this direction. And they say that I see them, their breathing change, or I get sense that it's sore. And I ask them, oh, is that sore? And they might say, yes. And I say, okay, well, what about in this direction? And then they say, oh, that feels good. I say, okay, well, then that's the way that we do that. That's the way you like it. And then my charting will reflect that as well.
What I was just going to say, TJ, is Robin was at your talk earlier today.
Oh.
And but it's okay for everybody else. But just this was directed to Robin, that we will, because you were gonna share your thing with the group earlier, right? So we can share your intake form with her as well. So.
And I guess a little.
I love that, by the way. I love
Yeah.
your three things, like what are you here for kind of thing. I love that. I think that's a game changer. I'm gonna borrow that.
I took that already because you said that like a couple months ago, and I took that. So I like that. I liked it a lot.
Chef's kisses.
It was a 10. Yeah, chef's kisses.
Yeah.
And then for me, like, because I see a lot of pelvic pain. And I always say the key to a good pelvic treatment is a good scalp massage. And so just because people really do enjoy, for the most part, like having their scalp treated. And so I'll give them like a 5-10 minute scalp massage, and I'll be like, so those scalp massage vibes that felt really good and really yummy, that's what I want to incorporate in that painful area. So if anything I do is outside of like those scalp massage vibes, then you need to let me know, and we need to change it up so it feels good. And changing that narrative with people where they don't have to like hurt to feel better. Like people get so emotional when they realize that like clinical interventions don't have to be painful. They don't have to hurt to feel better.
If I can add one more thing to all of that, and then we've got some questions and comments if you guys are cool with that. Just, Robin, be willing to change.
Yep.
Just constantly be willing to change, because our understanding and our learning and everything is going to change. So just be ready for it. A great comment from Kev again, which is good advice for all of us. Just attune to the patient, try to understand them and meet them where they are, then do what you can to help them on their journey to healing.
Yeah.
And then I know that our buddy Keith is directing this at us, but in reality, if you're taking the time to watch this tonight and you're learning from it and you're wanting to learn from it, this is directed at you as well, is that as somebody who has persistent pain, I so appreciate the work that you're all doing and your focused dedication on making change, all to best support and help people living with pain. We need more of you. So that includes every single one of you that are watching this tonight, that are engaging with us. Hats off to you as well, because you're making a difference with people. So keep it up. In Toronto, it's bedtime, so some people have to log off. We've been on for an hour now, but
thanks for coming.
Yeah, thank you very much for coming. Don't see any more questions. A couple of good comments about some research and Amy, what she's learning with psychological studies and how that applies to massage. Great stuff.
Yeah. Yeah. I was looking for it on the thing here. Actually, because I'm going to be doing a presentation for the RMTAO in June on psychological informed practice for RMTs. Just a little like spoily or a little treat. They found that at least the consistent message in the studies I've read around psychological informed practice and physiotherapy, one of the most consistent themes was humor in building therapeutic alliance with people. So if that therapist if they were able to build some kind of rapport that was based on like some kind of humor like element, those people actually had better therapeutic alliances with their practitioners. So be funny is a key takeaway there.
Yeah, but in all fairness, I've always said if I'm going to get in trouble from my college, it's going to be because of my sense of humor. So
yeah,
careful
with your humor.
It's all about knowing your audience, JJ.
Yeah. I have a hard time with that. So we've been on for an hour. For those of you who are listening in, Do you want us to keep going? Or get good after an hour? Because I don't know if there's other things that you guys want to talk about.
I do. I have a couple things.
Not you, Jocelyn. You're not allowed.
Yeah, you said enough.
No, I'm just kidding. Go ahead.
So I thought we'd circle back to this modality thing because we have some RMTs tuning in right now, or I guess most of them are RMTs tuning in right now. And given the light of like the BC RMT and like the MLD systemic review that came out a couple days ago and how that caused some upset, I'm imagining, I thought maybe we could talk about so something I've been thinking about over the last couple days is our investment in like these modalities, like and how we identify with modalities. Is that because we are trying to prolong our longevity as therapists?
Oh, what do you mean?
Because a lot of the time with MLD in particular, from at least talking to colleagues, they make the switch over to MLD or DNM because they want a lighter way of treating.
Or CST, I've heard that too.
Yeah. And so I'm starting to wonder if this is maybe something we haven't explored within the massage therapy world, is that our investment in modalities is to preserve our longevity as therapists.
Possibly, because I've seen it in the, in some forums where people ask, what do I do to have a longer career? And take this course. Because I mean, I took Graston because I wanted to use my hands less.
Yeah. And I feel like that's a very common topic, at least in the massage therapy pages I'm a part of, is that people are usually asking questions around, how do I save my hands? How do I save my shoulders? How do I save my neck? And it's always these modalities that kind of pop up. So I was wondering maybe if this is just an element into our narrative, like why we hold on to our identities with modality so much is because we want to preserve our longevity as therapists.
That's such a weird thing to me because I've been practicing since 2006. So I'm into my 15th. I've just passed my 15th year of practice, and I don't beat people up. I used to for a long time, but over the last number of years, I've totally softened up. You know what? Knock wood. I've never had a problem with pain or breaking down from massage. So I hear these things that you're talking about, Jocelyn, and I'm always curious. I'm like, what are you doing to people?
Well, I think too, what are you doing to people? And it's if that therapist holds the narrative of I'm fixing you, if that is also playing a part into that as well, because if that person perhaps feels overwhelmed or burnt out, I mean, if we're looking at a biopsychosocial understanding here of the therapist, that might also be playing a role there too. So that's something that's been banging around in my head a little bit.
But I think that also is like what you're just saying about the therapist fixing them. I don't want to make a blanket statement, but I'm probably going to anyway, is anybody that I've ever met that identifies as a craniosacral therapist, that's their intent, is that they think they're fixing people, yet they're using a lighter modality, lighter technique.
Yeah.
So then is that prolonging their career because they're using, or are they getting just as burnt out?
I don't know. That's a fair point, Jamie. I just figured that a large amount of these like individuals who are asking questions around, what do I switch over to because my hands are always hurting, tend to be like, I'm a deep tissue therapist, I'm a fascial therapist, I do these like, deep Swedish treatments. And then they're switching over to like craniosacral or MLD or DNM or something. So yeah, that's a good point though. Maybe I'll ask my craniotherapist at work what she thinks about that.
Yeah.
I'd always be curious to know too that if you say somebody came in and they had this kind of, say they were like a deep tissue therapist and then they decided to go to a DNM or a craniosacral kind of focus where it was a much lighter touch. I wonder what their perception would be, or what their patients' perceptions would be of effectiveness.
Well, and I think they would just leave. At least in my experience with like people I've taken on because of a therapist in the area, she like switched her practice over to like energy work, And so now I have the rush of new patients because they're like, yeah, I don't like that way that they're treating. So she just told me to move on. And I think that's something else that we have to be, at least in BC anyway, that we really have to be aware of, is that how lucky and fortunate we are with how busy we are here. And really, you can, in my experience anyway, like if you look at the clinic I'm at right now, today I had a wait list of 40 people. So I can really choose how I want to practice. And if someone doesn't fit within my, my frameworks or my biases, I can just let them go and fill that spot with someone else, like, immediately. So that's another ethical concern that I kind of have with BC RMT or BC massage therapy anyway.
Yeah, Laura makes a good comment here. She said, I do think there's an intention to fix behind seeking a golden modality, and that is the root of burnout, the blurring of those boundaries and becoming too invested in the outcome. That's a really great point.
Yeah.
For what it's worth, I mean, in that same realm, it'll be curious to see, like, I've just returned to full-time practice after being primarily at one of the massage colleges for the last 6 years, like on the admin team running the clinic there. So now that being pain science informed and catering my treatments, my interactions with my patients more to their enjoyment and not painful, and really asking them what it is that they want. They'll tell me exactly what they want. I think I'm asymmetrical this way and it concerns me, or I think I'm tight over here, or what have you. There's something about it that's been really freeing and feels physically easier on me. I don't know what the difference is. It hasn't been long enough. Just me isn't a good one person as a case study, not research. But yeah, I wonder about that fixing thing, needing to do a thing to tissues feels much harder than just, I'm going to touch you nicely. How do you like to be touched?
And I think that it kind of, because we are such empathetic people generally, massage therapists tend to be, if you hold that I'm going to fix you narrative, it almost hurts more when you're so invested in that outcome and then that person isn't getting better. We tend to be more vulnerable and more sensitive to that. So I think that's another factor in burnout.
I love what Kev just said.
Yeah,
I know,
you're bringing
reading
it up
it.
too. That's great.
That's a good one.
I think I've heard Kevin say this before because it sounds familiar, but I love this.
Kevin, you come up with some of the greatest analogies. I can't remember what the one was when we were in Surrey, but I was like,
It was the one about the tree.
Yeah.
And the
the tree in the wind.
Yeah.
Brilliant. But he says, I ask patients that expect or expect painful treatment. If you bang your head on a cupboard, how would you run your head to make the pain go away? As hard as painfully as possible, or more gently and quickly?
Right? Yeah.
Nice stuff. So we were just debating wrapping this up, but then Samantha's asking, could we talk about intent? But I'm wondering, intent in what way? Like intent of treatment or intent of what we're doing?
I like Anne-Marie's comment about letting go.
Yeah.
Great freedom of letting go of outcomes and enjoying the journey with your patient instead.
That's
great.
In my paragraph.
That's so good. That's 10 chef's kisses.
Yeah. I think that's so important. I think that's something that I wish that when students got out of school, they would, and you were touching on it earlier, Stephania, is that just like it's a journey, right? You're there to support and facilitate, and it's a journey and it's not a fix. And I think that I'm so glad you brought that up, Anne-Marie. That's such a great thing. It's so simple, but so effective. Mm-hmm. Yeah. I love it.
Okay. Well, that was a long, awkward pause. So maybe that's the mark to wrap it up.
Sure.
Samantha, maybe we can talk about that next time, or maybe if you fire us some messages, some DMs, then we could develop another one of these and we could talk about intent. I know we plan on doing a lot more of them. So
it's been a long time since we've done these. It's been since the summer.
Yeah.
We were rocking in the summer with them, but we should really do more of them. So if you guys have ideas or things that you would like for us to talk about, then by all means, send any one of us some messages. And we'll try to develop some stuff around it. And if you would like to come on with us, don't hesitate to reach out with that as well. We'd be happy to have you come on. Kev, come on and teach us a bunch of analogies that you were talking about.
And also, too, we if you guys are listening or watching, we subscribe to Jamie and Mine's podcast, where you get to listen to us ramble on about this, and we are going to have guests and people to chat with as well. So
Yeah, and there will be a new podcast episode coming out tomorrow morning, all about the psoas.
Hell yeah, the soul muscle.
Muscle of the soul. Yeah, so thank you to everybody who, or maybe the intention behind massage. I know for me that was a big change. I love that you're using SFN, so TPN and SFN.
yeah, great.
So maybe that'll be a conversation for another day because we've been at it for an hour and 10 minutes now.
Yeah.
I'm sure
Yeah.
people want to go to bed, and I want to go have a beer. So
You haven't been
Yeah.
drinking this whole time?
no, because I'm in that different room.
Oh, yeah. That's right.
So thank you to you four folks, and thank you to everybody who listened in and asked questions. I think this is actually the most engagement we've had on one of these yet.
That's
Yeah,
great.
So that's phenomenal. So thank you to everybody. We'll end her now, and then if you guys want to stay on for a minute, we can have a chat. But,
Yeah, thanks for another night of confirming my bias.
Good night, everybody.
Right.